We're going to continue in the section of late pregnancy complications with a discussion of preterm labor. So let's see how preterm labor can present on the Step 2 exam. The key to this question comes in the first line where we see that she's only 28 weeks pregnant. We go back to our first lectures in terms of definitions of pregnancy and know that she's preterm. In addition, she has symptoms of contractions, and on exam we see that her cervix is dilated. So when asked what the most likely diagnosis is, we've made our diagnosis of preterm labor. Her membranes are intact, and so she doesn't have PPROM. She doesn't have cervical incompetence because she actually is feeling contractions as opposed to asymptomatic dilation. And they're not simply preterm contractions because she does have cervical dilation. So let's review some of our definitions. Preterm births occur at less than 37 weeks gestation. They can either be spontaneous, so preterm labor, or indicated due to maternal or fetal disease, and about 20 to 30% of preterm births result from deliberate intervention. Preterm labor has a number of different causes, and it's always good to think back to our physiologic connection. So why would these things be causing preterm labor? So it could be due to activation of the hypothalamic pituitary adrenal axis, and this is due to maternal or fetal stress, which causes the premature onset of normal physiologic initiators of labor. It can also result from decidual hemorrhage or abruption, which causes irritation and contractions. It can result from inflammation, which also can result in irritation and contractions, or from pathologic uterine distension. And as we've learned, one of the biggest risk factors is multifetal gestations, although we can also see this with polyhydramnios or uterine anomalies. So let's review some of the risk factors of preterm labor. One is preterm rupture of membranes, which can increase the risk of contractions and onset of labor. The other is multiple gestations resulting in uterine distension, a previous history of preterm labor, placental abruption, and other maternal factors such as anatomic abnormalities or infections. Here on this hysterosalpingogram, we can see one of the major risk factors for preterm labor in a unicornuate uterus. This arrow indicates the left horn of the uterus as it goes out into the fallopian tube and spills into the abdomen, and here we see an absent right horn. This is a gross anatomic specimen showing a bicornuate uterus, another risk factor for preterm birth. So the presentation of preterm labor is pretty straightforward. Contractions plus cervical change between 20 and 37 weeks gestation is preterm labor. Now it's important that you have both contractions and cervical change. The diagnosis for contractions alone is preterm contractions, whereas the diagnosis of cervical change alone is cervical incompetence. Evaluation of contractions can occur by palpation or by external fetal monitors. Cervical change should be assessed by either a speculum exam or a gentle digital exam. Subtle changes are important in these cases, so serial examinations by the same examiner are optimal. So the initial evaluation of preterm labor is going to involve an evaluation of gestational age, fetal weight, which is assessed by using biometric measurements on ultrasound, as well as an assessment of the amniotic fluid index, which can be done at the same time, and a determination of the fetal presenting part, which can be done on ultrasound or on digital exam. In addition to this, a vaginal rectal culture for group beta strep and cultures for chlamydia and gonorrhea are often obtained at the initial cervical exam. In some cases, an amniocentesis may need to be performed if an intra-amniotic infection is suspected or in question.
The Step 2 exam may ask you about the next best step in management. There are a number of indications for delivery listed here. Severe maternal hypertension, preeclampsia or eclampsia, uncontrolled or unstable maternal cardiac disease, advanced cervical dilation, maternal hemorrhage in the setting of DIC, abruption, or bleeding in the setting of placenta previa, fetal death, chorioamnionitis, preterm premature rupture of membranes at greater than 34 weeks gestation, fetal distress, and intrauterine growth restriction with reverse end diastolic umbilical artery Doppler flow. If any of these are present at the time of diagnosis of preterm labor, the answer is going to be delivery on the Step 2 exam.
So if a patient presents with preterm labor and none of the other preceding conditions are met, this flow sheet can be helpful for deciding what to do next on the exam. So if a patient presents and they are between 24 and 33 weeks gestation, or the estimated fetal weight is between 600 and 2,500 grams, we would want to stop delivery if it was safe for the mother and baby. We would do this in order to give betamethasone in order for us to mature the fetal lungs, and we could stall or delay labor by giving tocolytics. On the other hand, if the patient is between 34 and 37 weeks gestation, or the estimated fetal weight is greater than 2,500 grams, we would let the preterm labor evolve and allow for delivery. So we introduced an important concept regarding fetal lung maturity in the form of corticosteroids, which are likely to show up on the Step 2 exam. Corticosteroids exist as either betamethasone or dexamethasone. The effects of betamethasone begin within 24 hours and peak in 48 hours. Typically, they'll last for about 7 days after administration. The goal for administering corticosteroids is to decrease the risk of respiratory distress syndrome and neonatal mortality. The physiologic connection here is that corticosteroids increase surfactant and thus quote-unquote mature fetal lungs.
So the goals of tocolytics are to delay preterm labor, to allow for administration of corticosteroid therapy, and allow time for transport to a health center capable of taking care of an infant at an early gestational age.
Some common agents include magnesium sulfate, which decreases uterine tone and contraction, and has the side effects which include flushing, headaches, diplopia, and fatigue. The side effects of drugs are a commonly tested topic, and for magnesium, toxicity can lead to respiratory depression and cardiac arrest. If you have a patient who presents with these things, you can check their deep tendon reflexes, which will be depressed if they have magnesium toxicity. If asked what the antidote is or what medication to give, you want to give calcium gluconate to counteract the magnesium. Other tocolytics include calcium channel blockers, which have side effects including headache, flushing, and dizziness. Beta-adrenergic agonists, such as ritridine or terbutaline, the side effects which include hypotension, tachycardia, and chest tightness. Finally, prostaglandin synthetase inhibitors, a very important side effect which includes premature closure of the ductus arteriosus, particularly when used after 34 weeks gestation. Since the fetal cardiovascular physiology can be a commonly tested subject on the Step 2 exam, we included a diagram here to review where the ductus arteriosus is, keeping in mind that the prostaglandin synthetase inhibitors such as indomethacin can close this, particularly when used after 34 weeks gestation. All right, we're going to move on in the section of late pregnancy complications to preterm rupture of membranes. So premature rupture of membranes is the rupture of chorioamniotic membranes before the onset of labor. It presents with a gush of fluid from the vagina. Preterm premature rupture of membranes, or PPROM, occurs before 37 weeks gestation. PPROM is associated with 30% of preterm deliveries. The major complication is infection, since the barrier between the vagina and the uterus is gone. Another definition, prolonged preterm rupture of membranes, is when the rupture of membranes has occurred for greater than 24 hours. The diagnosis is made based on a sterile speculum examination, which shows fluid pooling in the posterior fornix, fluid which turns the nitrazine paper blue, and when dried on a slide, the fluid has a ferning pattern. The physiologic connection here is that amniotic fluid is alkaline, having a pH above 7.1, whereas the vaginal secretions have a pH of about 4.5 to 6, and urine is less than 6. The paper turns blue if the pH is somewhere between 7.1 and 7.3. And thus, when you have amniotic fluid leaking down, the paper turns blue. You can get false positives with cervical mucus, semen, or blood. Now with the Fern test, the sodium chloride content in the amniotic fluid causes the crystallization in the ferns, which we'll see here in a minute. This is an example of ferning which you would see under the microscope as a result of the sodium chloride content in the amniotic fluid. Premature rupture of membranes can lead to a number of different complications, including preterm labor, which we've discussed, cord prolapse, placental abruption, and chorioamnionitis. In order to decrease chorioamnionitis, attempt to decrease the number of exams that you do.
There are a few additional treatment considerations. With preterm premature rupture membranes, we use corticosteroids before 32 weeks gestation, which is slightly different than preterm labor without rupture of membranes, where corticosteroids are given up until 34 weeks gestation. Additionally, antibiotics are administered, which are also gestational age dependent. As with all patients where GBS is known to be positive, penicillin should be administered. If the patient is greater than 37 weeks gestation and GBS is unknown and rupture of membranes has occurred greater than 18 hours, penicillin should be initiated for GBS prophylaxis. If the patient is between 34 and 37 weeks gestation and GBS is unknown, penicillin should be initiated. If the patient is known to be GBS negative, no antibiotics are required. Importantly, any scenario with signs of chorioamnionitis is an indication for ampicillin and gentamicin to be initiated. Finally, in the setting of preterm premature rupture of membranes at less than 34 weeks gestation, erythromycin and ampicillin can be given to prolong latency while awaiting corticosteroid activity.